Thank you, organizers, for giving me this opportunity. So, I would be presenting a mini oral session which was presented by John A. Kite at this ESMO 2022 in September. This is a randomized phase 2B study which evaluated chemotherapy along with the immunotherapy combination, which is the nivolumab and ipilimumab, in the metastatic hormone receptor positive and breast cancer. So when I was assigned this topic, I was thinking of whether I heard, I was reading it right, icon in breast cancer. So I came to know that icon there is both in ovary and the breast. So it stands for International Collaborative Ovarian Network in the ovary, and icon breast, it stands for immunogenic chemotherapy combined with ipilimumab and nivolumab. So that's interesting. And what is the rationale? Usually we think of immunotherapy only in the TNBC setting. So what happened, which is the rationale for developing this study? Actually, this hormone positive, HER2 negative subset of patients who were heavily treated, the immunotherapy as a monotherapy did not fare well. As evidenced in the Keynote 28 trial, the patients had just only 12% response rates, and the results replicated even in the Javelin trial with the avelumab, where only 2 out of 110 subjects who were outside the TNBC patients had responded. So immunotherapy as monotherapy did not work best in these subsets. So they tried the combination, that is the immunotherapy and chemotherapy. The checkpoint inhibitor with eribulin had no benefit in the hormone positive settings. But it was interesting that in the TNBC, the chemo and the immuno combination worked, as seen in IMPATCH 130 and the pembrolizumab trials. And the TONIC trial addressed the question that which chemo is better for inducing the immunogenicity, so that the PD-L1 blockade in combination with chemotherapy could be the best. So this trial found out that the anthracyclines had the maximum immunogenicity, which will have increased efficacy with the subsequent PD-L1 inhibition. So with this background, the study enrolled 82 patients who were metastatic hormone positive, HER2 negative, who had received no chemotherapy or at least one line of chemotherapy only. And the limit for the endocrine or targeted therapy was not set. They can receive any n number of lines of endocrine therapy or targeted therapy. And the duration of the chemotherapy received in the adjuvant or the neoadjuvant setting, especially the anthracyclines, which was the common standard drug being used in nowadays, is the DFI should be 12 months. So patients were randomized in 2:3 fashion to chemotherapy only arm, that is the arm A, and chemotherapy plus immuno combination in the arm B. The chemotherapy regimen used was the pegylated liposomal doxorubicin at the dose of 20 mg per meter square every 2 weeks. And whereas oral cyclophosphamide was given every 2 weeks out of 4 weeks with the dose of 50 mg per day. The nivolumab is 240 mg IV every 2 weekly, whereas the ipilimumab it is 1 mg per kg IV every 6 weekly. So the rationale for developing why to choose only this pegylated liposomal doxorubicin, the organizers the study has shown mainly the 3 reasons for that. The liposomal doxorubicin is selected to avoid steroids, and it limits the cardiac toxicity, which is expected with the conventional anthracyclines. And with the conventional anthracyclines, we are also limited by the cumulative cardiac toxicity. The dose is limited to just 6 to 8 cycles. But here with liposomal doxorubicin, with the metronomic chemotherapy, it can be given for a longer duration, that is approximately 2 years. And metronomic cyclophosphamide actually counters the regulatory T cells, which are immunosuppressive. So these all factors have put together, and this trial was designed such a way that patients with hormone positive HER2 negative breast cancer would benefit with a combination of chemo and immuno. So the primary endpoints were progression-free survival in per protocol population. So what is the per protocol population? So these are patients who have received at least 2 doses of the PLD and nivolumab, and at least 700 mg of cyclophosphamide, and at least 1 dose of ipilimumab in the arm B patients. So coming to the efficacy, The trial has found that there was no benefit in the progression-free survival with the addition of immunotherapy to the chemotherapy arm. And in fact, the overall survival was also not improved. And in fact, it was detrimental with a hazard ratio of 1.13. When they did a subset analysis also, even in the PD-L1 positive subpopulation, which accounted for 28 patients who were positive for PD-L1 by SP142 assay, there was no PFS or OS advantage. Coming to the secondary endpoints, which is the tumor responses, the overall responses as per RECIST 1.1 criteria, the combination arm had a higher responses, 32%, as compared to 29% only in the chemo arm. The clinical benefit, which is defined as a complete responses or the partial responses or the stable disease until 24 weeks of evaluation, is also higher in the immunotherapy and chemotherapy combination arm, 55% versus 48%. So as with any drug, we are worried about the combinations, how safe it is. So the endocrine related adverse effects were more naturally in the immuno-chemo combination arm, and most of them were the endocrine immune related adverse events, which were hypothyroidism and the hyperthyroidism, and the pituitary insufficiency, that is the hypophysitis, and the adenocortical insufficiency. And the non-endocrine side effects, as expected, were the pneumonitis, hepatitis, rash. They accounted for 2 to 8% of cases. The median duration of treatment was same in both the arms, but the treatment discontinuation rates were higher in the combination arm, which is 12%, as compared to 3% in the chemo-only arm. So interestingly, in a subset analysis, they found that patients who had immune-related adverse events of grade 3 or more, when they were analyzed after 4 months, they had a prolonged PFS with the combination therapy, that is the immuno and chemo, with a hazard ratio of 0.34. So the study concluded that the addition of nivo-ipi did not improve the PFS or the OS, but gave more immune-related adverse events. But there are some subset of patients who benefited, that is the ones who had immune-related adverse events. So biomarkers are needed in future to determine the selected subgroups who would benefit with the combination arms. Thank you.